Hello everybody. Today we are going to discuss acute kidney injury, indication of RRT and choice of modalities. So indication of RRT, patient with any acute kidney injury, the indications are metabolic abnormality, that is blood urea nitrogen more than 100 mg per dl, hyperkalemia, that is more than 6 ml equivalent with ECG changes, acidosis, that is pH less than 7, lactic acidosis related to the metformin use, then anuria or oliguria, then it is defined as if urine output is less than 0.5 ml per kg per hour for 6 hours, or if it is less than 0.5 ml per kg per hour for 12 hours, or more less than 0.3 ml per kg per hour for 24 hours, or anuria for 12 hours. Then fluid overload, that is any diuretic sensitive or resistant. Then dialysis dose. There is no benchmark for the dose and the intensity of RRT used to treat AKI. Many experts suggest that IHD in this setting should at least achieve the urea clearance recommended for patient with end-stage renal disease, although there is no data validating this approach. The urea clearance can be quantitated through KT by V or urea reduction ratio. The KT by V is the dimensionless index of dialysis dose, for which K is the urea clearance of dialyzer and T is the duration of dialysis and V is the volume of distribution of urea. So KT by V is thought to be the measure of time averaged urea clearance and is determined by applying pre-dialysis and post-dialysis urea and volume data to be published uh, to published formula. KT upon V for each IHD should exceed 1.2, assuming single pool of urea kinetics. Alternatively, some programs targeted urea clearance of more than 65% or 70%. So this urea reduction ratio is calculated from the following formula, that is pre-dialysis blood urea nitrogen minus post-dialysis blood urea nitrogen upon pre-dialysis blood urea nitrogen. So it is important to note that adequate urea clearance does not ensure that ultrafiltration needs are met. The additional RRT may be required to address the volume overload. So assessing the dose of continuous renal replacement therapy. RRT delivered is traditionally assessed by measuring clearance of urea. That is the rate of plasma cleansing required to account for a rate of urea removal if treatment separated all urea from plasma proceed. Such measurements are comparable to endogenous renal function assessed as glomerular filtration. ATN and the renal studies were large multi-center randomized controlled trial investigating the effect of RRT dose on survival and were conducted in ICU throughout the US and Australia and in Australia and New Zealand respectively. ATN study randomly assigned critically ill adult with AKI that require RRT to high intensity or low intensity RRT. High intensity therapy consisted of pre-dilutional CVV-HDF to provide total influent flow rate of 35 ml per kg per hour or 6 sessions of IHD per week. Low intensity therapy consists of CVV-HDF to provide total influent flow rate of 20 ml per kg per hour or thrice weekly IHD. Now, the conclusion of both these studies are ATN renal studies have now established upper limit of intensity for RRT. In addition, they found no evidence to suggest that any specific subgroup would benefit from higher dose of RRT, refuting previous small studies. Finding of this study, however, do not imply that estimation of the dose is unimportant. Dose response relationship is likely at lower treatment intensity, that is less than 20 ml per kg per hour, and a significant minority of the patient still receive treatment intensities lesser than this. Given the likelihood of dose response relationship somewhere below 20 ml per kg per hour, delivery of the doses lower than this should be avoided. To ensure the outcome similar to those seen in ATN and renal trial, clinicians should prescribe CRRT on the basis of patient's body weight to establish effluent flow rate target of 20 to 25 ml per kg of body weight per hour. Then IHD or SLED provide hemodialysis 3 times a week and monitor the delivery dose to ensure the delivery of single pull of KT by V of 1.2 or more. So CRRT employ the large caliber catheter in systems of anticoagulation to maximize filter life. Ensure the effluent flow rate of 20 ml or more per kg per hour. In a convective system which employ the renal filtrate at 25% to the prescribed effluent rate to adjust for dilutional effect if pre-filter RF is used. Now, modality selection. In the United States, the hemodynamically stable patient with AKI is generally managed with IHD. The technique provides rapid solute clearance and volume removal, but it is of limited utility in setting of hypotension. Unstable patients are often managed by one of the CRRT. Patients may move from one modality to another with changes in the hemodynamic status. Dialysis sessions are delivered at a minimum of 3 times per week. More frequent sessions are often required to achieve specific volume and metabolic target. The average ICU patient with AKI receives 3.5 liters of fluid daily. It is challenging, if not impossible, to mobilize this volume over three IHD sessions alone. That is, IHD may be supplemented with additional ultrafiltration sessions to meet volume needs. Peritoneal dialysis management of AKI has declined markedly, though it remains important ICU modality in developing countries. Furthermore, recent meta-analysis reported no difference of pool mortality between the patient with AKI treated with the peritoneal dialysis versus IHD or CRT. SLADE is used by minority of program, often in response to resource consideration. Now, which modality should be used, IHD versus CRT? Modality selection in AKI is highly variable and appears to be changing in favor of CRT. Internationally, CRT is often preferred modality for managing AKI. The shift towards CRT is driven by a number of important practical as well as theoretical advantages for CRT over IHD. CRT induces less hypotension and is better tolerated by patients with unstable hemodynamics. CRT permits removal of large fluid volume without inducing and exacerbating hypotension. Since CRT induces less hypotension, it may promote renal recovery from AKI by avoiding repeated episodes of renal hypoperfusion. CRT provides greater solute clearance than alternate day IHD. Since CRT minimizes or limits hypotension and disequilibrium, it may better preserve cerebral perfusion in acute brain injury and in hepatic failure. The convective clearance of CRT, particularly CVVH, may remove harmful immunomodulatory substance in sepsis. In summary, no evidence exists to support the survival advantage of specific RRT modality for AKI. Some prospective trials suggest the improved hemodynamic stability with CRRT, and some retrospective analysis suggest enhanced recovery of renal function. In many circumstances, modality selection is guided by medical and nursing expertise and by the availability of the equipment or nursing support. When both modalities are available, selection should be individualized according to clinical status. So most tertiary care centers offer CRRT when hemodynamic instability is present. IHT can be used successfully for hemodynamically unstable patients, provided ultrafiltration rate are reduced by increasing the frequency and duration of treatment. Now, what are the recommendations? It is recommended to start CRRT over IHD for the management of AKI in following clinical setting. Hypotension requiring pressure support, massive volume overload with high obligate fluid intake, higher catabolic patient who have failed to reduce blood urea nitrogen to less than 80 mg per dl over 3 IHD sessions, and AKI setting of the severe liver failure. Now, the technical consideration, we favor CVVH because of its simplicity. There is no evidence that CVVH is associated with better outcome than CVVHD and CVVHDF. Regardless of CRRT modality, the prescribed effluent volume should be 20 to 25 ml per kg per hour. Now, regarding discontinuation of therapy, Recovery of renal function is traditionally defined by the reversal of oliguria and the progressive decline of serum creatinine. Increased urine volume may not be apparent in non-oliguric patients. If the CRRT patient is intensively treated, the serum creatinine may be normal, making it impossible to detect spontaneous decline. We define recovery of renal function according to the criteria used in the 18 study. Urine volume exceeding 30 ml per hour, 6-hour time urine collection to compute creatinine clearance. Now, this is the algorithm showing the discontinuation of RRT in the ICU patient. So first, the patient should be stable, that is stable hemodynamics, stable respiratory function, balanced fluid status, no impending renal incident. Then the urine output should be without diuretics, patient should maintain urine output of 400 to 1000 ml per 24 hour. If patient is on diuretic, then 2000 ml per 24 hour. Then about the creatinine clearance, 24 hours or 4 to 6 hours, it should be 15 to 20 ml per minute and spontaneous decrease in serum creatinine. Then we can attempt the weaning of acute RRT. The creatinine clearance is calculated by urine creatinine into urine volume upon plasma creatinine upon 360. If it is less than 12 ml per minute, continue CRRT. If it is 12 to 20, individualize ongoing CRRT. And if it is more than 20, then discontinue CRRT. Thank you.